which are required when one is considering incorporating toric IOLs into his or her practice here. So the first is to know where you would not want to use toric IOLs here. So corneas which have been altered by scars, corneas which have ectasias, post-LASIK corneas where the irregular astigmatism quotient is higher, then these corneas are not corneas which would be befitting a toric IOL implantations. Eyes with zonular instability, for the simple reason that rotating the IOLs in the bag, which probably compromise the bag status, is again a no-no for implanting toric IOLs here. With a posterior capsular dehiscence, again for the same reason that rotation and placement on the right axis is going to be unpredictable. So posterior capsular dehiscence is also one of the contraindications here, where there's poor pupillary dilatation. Then you would probably need to augment with intraoperative pupil management devices for better visibility if you're doing such cataracts here. And eyes with prior VR surgeries, glaucoma surgeries, these are eyes where the ocular surface is compromised and the component of astigmatism is something which is going to be difficult to control in these eyes. So this is something you need to be considering, but by and large, with the way IOL implantation and IOL practice has changed, most of these indications have now moved on from being absolute contraindications to relative contraindications. So that's how the scenario of toric IOL implantation has changed with time. So what do you need to know next? You need to know the evaluating devices which will help you to estimate the amount of pre-existing corneal astigmatism here. So what are the devices which you have in hand is that your simple manual keratometry. You have automated keratometry, whichever device you choose to have, either IOL Master 700, Lens Star 90, or very other entrants which are there. You have the OpScan 2, the Pentacam, the Galilei, the Cassini analyzer, eye trace, and the intraoperative aberrometry by form of the Aura. So these are the various devices which I have used and have experience, and these are ones which will help you to estimate the quantum of preoperative astigmatism here. So when you use evaluating devices, I think keratometry has a very imperative role in the amount of astigmatism which you are estimating, and also in the calculation of your spherical power of the intraocular lens which needs to be implanted here. So evaluating ocular surface is a very imperative process, and most of these patients, being elderly, postmenopausal women, having other associated diseases like rheumatoid arthritis, Sjogren's, and if their ocular surfaces are compromised, that's something you need to optimize and evaluate these with the ocular surfaces by simple in-office ocular surface evaluation tests, or if you have a dry eye suite to your axis, then ocular surface analysis looking at the tear film breakup time, and various other parameters will help you to understand whether you need to optimize the surface further before you move on to finalizing the IOL power estimations here. So this is one scenario where you will really need to look at the surface more carefully here. Looking at the ocular aberrations is one which is important to look at the multifocality of the cornea, which you are going to be treating with a toric IOL implantation here. So those corneas whose multifocality, whose Q values have been altered by either they have higher quotients of irregular astigmatism by something like ectasias, keratoconus, or there is a post refractive surgery component here, corneal scars, and these eyes are eyes which have higher order aberrations here, and in the event of presence of corneal higher order aberrations, then you would not want to a toric implantation, because that's going to make the patient more unhappy here. So that's something, please remember, those aberrations which are arising because of the lens, the lenticular aberrations are what we can correct, because you're removing the lens and you're replacing it by an intraocular clamp. But those corneal aberrations, if they are very high, then these are going to be unhappy patients, because those aberrations are going to persist after your surgery, and your toric implantation is not going to correct them. So that's how you learn to evaluate in which scenario, in the presence of irregular astigmatism, you can implant a toric or not a toric here. So pretty much we do see patients like this most of the time when they come and they are elderly. You have thickened lids here. They do have meibomian gland dysfunctions, and these are eyes again which need to be carefully evaluated for their keratometry and for their astigmatism estimation. And again, intraoperative copious use of viscoelastics on the surface so that the epithelium is not compromised is something which you need to look at in these patients. Yeah. Okay. Optimizing the ocular surface in the perioperative period is imperative for the reasons which I've already emphasized to you, and that's going to be sometimes the most important aspect when you're managing these eyes. So what are the steps you need to know of? So I've already told you it's preoperative planning. So spend some time. It's not just looking at the cataract and looking at the intraocular pathologies which are associated or comorbidities or posterior segment evaluation. You will also need to spend your extra few minutes to look at and please finalize your IOL power and the lens and your other parameters before you take the patient onto the OTO and before you send the patient on for your counseling here. On the day of surgery, what's important is the marking of the axis. So a proper and improper marking several times would be probably the reason why the patients are unhappy or is a wrong implantations. Again, remember, marking most of the time our patients are in the supine posture, in the sitting posture, and when you're doing surgery they are supine, so you will have to consider some amount of cyclotorsion in these patients when you are implanting toric IOLs, more so if the quantum of astigmatic correction is going to be higher. Cyclotorsion component is something which needs to be considered in these patients here. Proper intraoperative alignment. The error which I do see my residents making commonly is erroneous placement of the Mendel's gauge when they are placing to mark. So if they do not know how they will have to orient the axis marker on the ocular surface, that can also lead to errors when they are implanting the IOLs. And of course the postoperative management is probably not going to be possible given the limitation of time that would usually largely cover if your lens is implanted in the long axis. Then how would you probably manage that scenario? And I think I would ask Vanitha to incorporate this as a separate talk next time, because that will help people to understand. So it's not only the pre-surgery and surgical component, but I think part of it does get covered by refractive surprises by I think Rishi covers this aspect when he's taking. So you also need to know the magnitude of astigmatism, the axis of astigmatism, the realistic expectations of the patient, what is the type of IOL you're implanting, because we now have toricity, which is not only in monofocals, you have multifocals and you have trifocals, which are also coming with the toric components. So this is something you need to be aware of here, and also look at the ocular comorbidities of the patients, not just surface comorbidities, but also the other limitations which would limit the vision capabilities and potentials of the patient, and particular attention to the IOL power calculation here. Cyclotorsion, as I already told you, the range of cyclotorsion could be as high as close to 30 degrees here, and it can be over about 60 cases or above can have a higher quantum of cyclotorsion here. So that's an aspect which you need to look at, and this is going to then alter the preciseness of your toric implantation here. So hence you have devices which help you to gauge the astigmatism intraoperatively as well, or image guided devices which have come in preoperatively as well to enhance your results in quantum of astigmatism estimation here, and translating it onto the patient irrespective of the position the patient is in. So manual preoperative marking could be conventional 3 steps or 2-step ones, which are manual methods here in forms of a bubble marker or the pendulum marker here. I think most of us do still use this in our practice, and it works perfectly well once you have perfected the technique of using it. Image guided ones, you have preoperative and intraoperative. The preoperative one includes the Varion, which is the cataract refractive suit, which helps to gauge your intraoperative astigmatism, and you can it's transferred onto the console, and then this will help you to modify or to implant your lenses. The intraoperative one, which is more sophisticated and more expensive, is the ocular response analyzer, which you would need to do the intraoperative intraoperative aberrometry. I think because of lack of time, I'll just run through. Please remember, one improper method of aligning your for axis marking is here when it's not passing through the center of the pupil. So correct axis, correct estimation of the slit lamp guide is important, so that you mark accurately in these patients. These are the common errors. Some pictures of the bubbles. You do have apps which can help you and guide you for toric implantations and for marking as well. These are some of the apps, but I don't personally use them here. I think we'll skip the surgery. It's pretty much similar, but just remember, when you're implanting the IOLs, you'll probably implant them 10 degrees short of the intended axis, so that you always rotate your lenses clockwise. So you have that amount of leverage for the IOL rotation when you're removing the viscoelastics. So that's something you need to be wary of when you are implanting intraocular IOLs. These are pictures representative of the use of Varion during surgery and how the Varion marking helps you. So these are markerless solutions, and these Varion images will appear in your eyepiece. So they're also there on the console monitor, and the console monitor helps you to guide, and you do not need to mark these solutions, and this takes care of the cyclotorsions of the patients as well here. So those are simple alignments. We won't run through the videos. You also have systems which are there in the microscopes, which will help you to gauge your astigmatism, and that is again another markerless solution, and really helps you to look at. These are those markerless of Varion, and now we also have these incorporated in flax, the way you do your capsulorhexis, which marks the capsulorhexis margins, and then you can look at and use it for placing your IOLs here. I think this is just a representative image of the aura, which images intraoperatively here, and it then moves on, and the console chooses the right power of the IOL and the toricity of the IOL which you need to implant, and once you've implanted, it images and gives you which way you need to rotate, and if you're on the right axis, it says no further rotation required here. So these are all sophisticated ways of which you can, these are post-operative estimations using the eye trace, which will help you to show how much of rotation is there, and if you need to manipulate these rotations, or if you need to go back to rotate the IOLs in the event if the placements are erroneous. Yeah, I think I will stop here in the interest of time, and perhaps we can take more during the discussions. Thank you very much.